and she has a special interest. She has a special interest in integrating pain and palliative medicine to the mainstream. Um, she is a certified pain specialist as well as a palliative care specialist. She has done her global fellowship in palliative medicine from Pallium India. And yeah, so we will wait till Dr. Punitha joins. And if you have anything else to discuss, then we can discuss till Dr. Punitha joins.
Punitha madam will join in less than 2 minutes.
Okay. So just want to ask you, are all of you going through the different modules before you attend these sessions?
Madam joined.
Okay. So I think Punitha, I already introduced you,
Okay.
and you can straight away go to the session.
Okay, sir.
And I think we can take more time because there is no case presentation today. So you can take
Okay.
as much time you want to discuss the patient stories.
Okay. Okay, sir. Thank you, sir. Is my screen visible?
Yeah, it's visible.
Okay, is it in this presentation?
Yeah, it's slideshow. Yeah.
Okay. Okay, sir. Thank you. And good evening, one and all. It is absolutely a pleasurable thing for me to present this topic of pain in front of you all through Pallium India. In fact, I learned all my sir. Am I audible, sir?
Yes, you are.
Okay. In fact, my palliative practice started with Pallium India. Slowly, month by month, and every year, I got confidence in practicing palliative care and prescribing opioids with every single module of Pallium, and they have handheld me in various different ways. So I feel it is one of my responsibility also to share the knowledge what I gained. So coming to the and introducing myself, I am Dr. Punithavathy Dhanashekaran. I have done a diploma anesthesia in St. John's Medical College and DNB anesthesia from Satyasai Institute, Bangalore. And I've been working in anesthesia for the past 15 years, and I did GFPM last year. And I'm currently working as an assistant professor in the Department of Anesthesiology in KMCH Medical College in Coimbatore. And recently, this year, I have started the division of pain and palliative in the anesthesia department itself. And we work like half a day on alternate days for pain and palliative. Our OP runs half a day only on alternate days. So going to my presentation, I start with some basics which we should never forget. It is a kind of, I planned this session to be a wrap-up session for pain. In fact, you all would have gone through all the materials already. It is all loaded with a lot of information. So I tried not to stuff with too much information, but some basics should never be forgotten. So I'm just revisiting very basic concepts, and then we'll go for some case discussions, and we'll have some one-on-one discussions also, like you can share some experiences of yours also. So this definition of pain should never be forgotten, and how the ISP defined pain. We all know the first three components. I divided the definition of pain into 4 parts. All these things are very much well known for us, but the fourth part, what they have added, is my favorite. So if we go through every single aspect of these 6 notes, extra key notes, what they have added, we will evaluate pain. We will never miss evaluating pain in total. The total concept of pain will come within these 6 keynotes. So without understanding all these things, we cannot really treat pain or write a prescription. So for that convenience, I'll just go through one after the other. Okay, so pain is always a personal experience influenced by biological, psychological, and social factors. What does that mean? When patient tells pain, we better believe that. We cannot just tell that they are feigning or they are exaggerating. Patient is the best. We do not have an algometer to measure pain. Like for if we have temperature, we can measure with thermometer. But for measuring pain, we do not have a device. We have to ask questions, evaluate, and clinically only judge. The second thing is, as pain and palliative practitioners, we should understand that pain is different and nociception is different. Nociception is just an electrical phenomenon. From the receptor to the brain, it just the electrical signal is carried. But pain may be phenomenally high than the nociception. Sometimes nociception will be very heavy, but still patient might be tolerating the pain. So pain is an experience. We should treat that experience. We should not be focused on treating the nociception alone. And through their life experiences, every patient will have different concept of pain. When we talk, this is where the concept of good communication comes in. When we talk, we can understand what does the patient really expect from us. How should I treat her pain? How should I dose and all? We will come to know only by proper communication. Then the fourth one is person's report of an experience of pain should be respected. That's the first point I told. When patient tells that it hurts, then it is pain. And the fifth one is pain has an adaptive role. Acute pain has an adaptive role. It helps. But when it comes to chronic pain and cancer pain, many of the times the ADLs are affected. The social aspects are lost. The psychological well-being is lost. So we always better treat the pain when we see pain. So we cannot keep postponing that. This is not a very big pain. I need not treat. So we have to evaluate in total. Social, psychological aspects also we should think about and then treat pain as a whole concept. And then the sixth one is very important. Verbal description is not the only means to express pain. When patient is on ventilator and on tube, we can always see when patient is in pain, the need for fentanyl infusion, what goes in the ICU might be increased. The need for sedation might be increased. He might be constantly triggering on the ventilator again and again. He'll be fighting with the ventilator. All these things tells that we'll have to see what's happening. Just by increasing the infusion is not a solution. We should see what is a pain, where is a pain. We better assess when patient is awake and then try to treat. Or if patient is not getting awake, patient is drowsy, we should consider this, he has pain, and we should look for pressure source or the tube is irritating, or we should really look for the cause for pain. So I have written it as inability to communicate is not equal to no pain. Just because somebody doesn't tell, it is not it doesn't tell that they have no pain. So this concept will come into practice in children, neonate, intellectually challenged people, and then in patients with dementia and Parkinson's and all, they cannot communicate to you that they have pain. They'll be having bed sores. They'll have immense amount of pain there, but they'll not be able to tell us. So we should always remember this as pain and palliative physicians. So coming to the next important part is when we are wrapping up this pain session, you have gone through 14 modules, I think. The first 5 modules will be on the basics of pain and assessment of pain. So this is a very important thing. This is like we can multidimensional pain assessment also we should remember to do, and unidimensional is always we do. We ask him, how will you rate your pain? We show a scale and we ask the patient, out of 10, how much do you have pain? If we don't do this, we are not even a beginner. First, as a beginner, we'll be unidimensionally measuring pain with various scales available, like Wong-Baker scale, numerical rating scale from 1 to 10, or a visual analog. We can ask them to show with finger where is the pain, measure that, and see the severity. We should use these scales to follow up the patient. Like first time before you prescribe morphine, show the scale and ask how much pain he has. And after morphine, you ask them, they will correlate. Many of the, we think patients are not able to tell us, but every follow up, they will be able to tell. Many times patients themselves will tell, madam, after this dose, the pain is now not like 7 or 8, it is less than 5, I can bear it. So we can easily dose, we can give the for incident pain or breakthrough pain, we can decide our doses if we are assessing and quantifying the pain in the right manner. The last two scales are cry scale, nip scale, flag scale are for used for pediatric patients. And then the pain ad scale is a commonest scale which is used for advanced dementia patients. We should be aware of these scales. When we start using it, we'll get a hold of it. We don't have to really be using everything in one go, one after the other. As we initially, when I started my practice, I was only using this visual analog and numerical scale. But now slowly, as we increase in our experience, we can learn how to use the other complex scales also. The other important questionnaires, multi-dimensional questionnaires, which I will have in my pain and palliative OPD is brief pain inventory, fibromyalgia questionnaire, and DN4 questionnaire. This will give us an all-round understanding of the pain of the patient. In fact, the total pain we will be able to understand, because most of the chronic pain patients and the cancer pain patients will have coexisting depression. They will have insomnia. They will have multiple other problems coexisting, either due to the chronic pain or independent of the pain. So for such patients, if we fill this inventory at least once when we meet them for the first time or the second time, we'll come to know in what aspect should I really treat this patient. The last questionnaire, DN4 questionnaire, is for neuropathic pain. If these questionnaires, we don't have to memorize anything in this. We just have to download this. All printable versions, PDF versions are there. Just keep it in your desktop. When you know a fibromyalgia patient is coming, take a printout and check the boxes and total it and see, will this patient fit in fibromyalgia diagnosis. Take a DN4 questionnaire printout and just tick and see, this patient has told burning, this patient has told shock-like sensation, such things, and then see whether she has a neuropathic pain or not. By using these scales and assessment tools, they really help us in guiding what drug should I choose. Should I increase my dose or do not increase my dose? And evaluation and re-evaluation is a continuous process in any symptom management. In palliative care, especially for pain, we have to keep reassessing and re-evaluating. Okay, coming to the next. This is one thing which we should never forget. We should evaluate pain in the right way, so that my favorite is that Socrates. It starts from site, onset, character. And one more good habit is all of us should have a, like how in Pallium, OP and IP clinical note sheet itself, they'll have a body map. So we should also practice the same way. We should have a body map printed in our thing, or at least we can draw by hand and mark pain A. One patient may have multiple pains. So the first and primary pain, you mark it as A and start rating the onset, character, radiation, and exacerbating and relieving factors for pain A. For pain B, some patient might have multiple site pains. No? So we should have a body map and treat accordingly. We should have an all-round understanding of what site pain has reduced with my dose. Did this site pain reduce with my treatment? So for follow-up, that body map is going to be helpful. And for a systematic way of asking questions, these kind of acronyms like PQRST and Socrates will help. So as we assess, there are certain things we should remember in treating chronic pain and cancer pain. The first 3 points what I have put is hyperalgesia, allodynia, and sensitization. Many times we think that I cannot really take history from a patient to understand whether they have these features. So I used to tell this example. One of my fibromyalgia patients will tell that just her sari touching, her dress touching her shoulders will cause pain. Her hair used to be long and the hair is touching and I'm getting pain whenever my hair touches. So she cut her hair short. So these things gave me some clue that, okay, that means some thing which is a non-nociceptive stimulus itself is giving pain, means it's called allodynia. So these things will give us clue to pinpoint on diagnosis and our management also. And then the last 3 points, what I have mentioned is very important to understand cancer pain. The burden is so much. We should all know about taking a proper history for cancer pain. We have something called background pain and breakthrough pain. Many of the anesthesia colleagues will already know how to treat background and breakthrough pain, like you give PCA infusions and all. But in our thing, in chronic pain, we will be giving for background pains, we call it as stable pain, and we have a prescription for it. And for incidental pain or breakthrough pain, we will have SOS doses, or we call it as PRN doses. So we will have a fixed dose and a routine dose, and along with that, we will be prescribing an SOS dose or a PRN dose. For that, we should understand when does a breakthrough pain happen, what time of the day she is telling pain, is moving her from side to side for dressing change causing the pain, is it's the patient is going sitting in the toilet is causing pain, or we should really dig in the history to find out when does the incidental pain come. Some people will tell, when I do deep breathing it comes, when I bend forward it comes, or when I move from lying down to sitting it comes. So these kind of understandings will really help us to tell the patient when to take that SOS dose or the PRN dose. And there is one concept of breakthrough pain called end of dose failure. This happens when we are timing. Especially it happens in a sustained release. In my small experience, I have seen in sustained relief tablets, they have end of dose failure. So I tell them to take one instant release morphine, one plain morphine, before that, or next time when they come, I try to increase the sustained release dose also. So this concept we should actively look for. We should ask the patient, what time is your pain increasing? So many patients, after a few weeks or months, they will nicely tell us, come back and tell us, doctor, 8 o'clock before I take only my pain is starting. So can I take 8 a.m. and 8 p.m.? We write sustained release tablets. But some patients will ask, can I take it at 7 p.m. itself? Can I take it at 6 p.m. itself? Then we should understand that this end of dose failure has occurred. Or some patients will tell, if I make it 20, there was one CA pancreas patient, he used to come and tell, if I take 20 mg morphine in the morning and 20 mg morphine in the night also, I am getting pain by before 8 o'clock. So for that particular patient only, I put TID of a sustained release. And then after some time, I gave him instant release morphine also to take it just whenever his pain starts first. Like at 4 o'clock or 6 o'clock, whenever you have pain, you take one SOS tablet. So this kind of flexibility we can give to the patient, we can communicate to the patient, we can retrieve information from the patient only if we know these concepts very well. And then this is a time-tested way of handling patients on opioids, on powerful, like strong opioids. Not only strong opioids for that matter, any symptom management in palliative or in general medicine, we have to do in this order only. This is a wonderful acronym. We will not get lost if we come to this kind of way of handling the patient from the evaluation to the follow-up. So this EMA, this is taken from Twycross and Wilcock. First thing is evaluation. So until now, I was telling you about evaluation of any symptom. For now, we are talking about pain, but this acronym can be used for any symptom in palliative care. So let us take pain. We have to evaluate it in multiple dimensions. We have to be sure that we are treating the right kind of pain. Am I treating a nociceptive pain, or am I treating a neuropathic pain, or is it a combined pain? If it is nociceptive pain, is it somatic pain, or is it visceral pain? We should have the understanding before we are going to choose the analgesic for it. And then we should also explain to the patient and the family about these things. Opioids, we should have good communication. There should not be any communication gap. In fact, if the patient is not able to understand, we should have the family member who is very responsibly able to give the tablet on time. Many times I see a patients like, if we give 4th hourly morphine, they will not be able to give. That is why sometimes we change over to sustained release morphine. But some patients, one of my own relative, he was not happy with sustained release. I have to go back to an instant release only. Every 4 hours, he is happy with 10 mg Q4H, and in the night only he takes sustained release 20, and then in between the night, if he gets pain, he will take, or he generally doesn't wake up in the night, but in the daytime he is not at all happy with sustained release. For such patient, we should be able to talk to the patient and understand what is he comfortable with. If patient is not happy with sustained release, we don't have to be keeping them with sustained release. Go back to plain instant release morphine. So such communication gap should not happen in case of strong opioids, especially because we are going to find out if patient is having side effects or toxicity and the compliance by our communication only. So taking history is very important. And whenever they come for refill, you are going to write the repeat prescription. That time we ask, how many did you use? How many morphine do you have left over now? Some patient will come back and tell, all that instant release morphine is there, doctor. That brown color tablet only I have taken. White color tablet was instant release. They will tell that is still with me. Then I understand that this is stable pain. Then some patients are there, they will tell that brown color tablet, the sustained release one, did not work for me, doctor. This white tablet is helping me. You write more of white tablet for me. Why don't I have it regularly? So we have to understand from their history, from the data they are giving, we should understand when can I increase the dose. Okay, if they are telling SR is not adequate, then I should go up on SR dose. If still it is not adequate, get them back to instant release morphine. And then management, M for management is, and we have to devise individualized treatment, patient-centric plan. That is what I was telling before also. For every patient, it will differ. So I used to write bisacodyl 10 mg for everyone. That is what we are taught and we learned. But some patients will come and tell, don't give me 10, give me only 5. I am getting loose stools with this. So then such patients, you have to individualize. We have to do patient-centric treatment only. Some patients will tell, you give me 10 mg bisacodyl, but I'll take it on alternate days because I'm not having any constipation, even with morphine. So such things also happen. We should be open-minded to tailor-make the decisions for each and every single patient. And then some patients will tell, you give me syrup only. Some patients will you give me tablet only. So we should be able to individualize for every single patient. And the second M is monitoring. It is very important. We should be very cautiously asking for questions of side effects of strong opioids. Do you have first 3 days? Anyway, prophylactically, we should be writing metoclopramide for vomiting prophylactically, and for constipation prophylactically, we should write the stimulant laxative. The commonly used one is bisacodyl 10 mg HS in the night. And then ask them for, did you have vomiting? How was your pain? Did you have any excessive drowsiness? Many of the time, I tell the patients that it is expected for you to be little drowsy and tired for the first 3 days until the medicine is getting used to your body and you are getting used to the medicine. So for 3 days, don't get worried if you are excessively drowsy. But if there is something alarming, please call us back. Like that, we should give a phone number and tell them, keep the channel of communication open for the patient. Otherwise, prescribing a strong opioid and closing the channels of communication is can be disastrous sometimes. So we should always remember that continuous close monitoring should be done, especially until the patient comes to a stable pain and stable requirement of opioids. Then the last one is attention to detail. So not always that every pain will respond to opioid. Sometimes some patients will have an inflammatory coexisting thing where you have to add an NSAID, or some pain, bone meds and all will require a radiotherapy. Sometimes palliative chemo and size reduction of the tumor size will help reduce that edema around, and sometimes adding steroid will reduce the edema around and give lot of pain relief. So we cannot always think that I have given morphine for this pain and I have increased the dose, now patient should feel okay. We should not handle in that attitude. Every time we should reassess and see, I have given morphine, this patient was in stable pain for last 2 weeks, what happened suddenly that now he is telling that this morphine is not helping, this 20 mg BD is not helping, this 10 mg, what is happening now newly, what did happen? So we have to ask what else happened. As you talk to the patient, you'll come to know. Then they will sometimes, many times I have found out that they will tell my back is aching suddenly. Then you send for an X-ray or a CT scan, you find a vertebral mets that time. And sometimes they will tell hip femur mets can be developed. Or sometimes the new pleural effusion would have come. And such things. Some and edema can come. Some lymphedema would have come. So when we are treating the right, we have to use a multidisciplinary team approach. When we are not able to find out, refer back to the oncologist or to the treating physician, whichever the surgeon or the pulmonary, whoever referred to you, treat. Send the patient back and tell that patient's pain is becoming refractory. Do you think anything else is happening? And if you think in a total aspect of pain, psychologically patient is having some aspects which is making you feel that the analgesia is inadequate. So we have to have a psychological evaluation also. Nursing intervention, sometimes for this bed sore related pain and all, we cannot handle everything by as a palliative physician. It is a multidisciplinary approach only. Nursing input and nursing help will be phenomenally doing miracles in reducing the pain. Right kind of dressing and right kind of antibiotic put in the right time. If it's infectious pain or inflammatory pain, giving an empirical antibiotic and all will make lot of change. We need not blindly increase the dose of morphine just because patient is telling I'm not getting relief from the pain. So, and another one important member of the multidisciplinary team is this physical physiotherapist or the physical medicine, physical and rehabilitation medicine doctor. They can give us very valuable inputs in how the patient should sleep, or how should he turn and wake up, how should he mobilize, and all that. All these inputs, or where many is this patient developing some spasticity, all such things the physical and rehabilitation medicine doctor will know, or the physiotherapist can help us. So we should take inputs from other team members also. So this is the most important slide of this presentation. Whenever you have a symptom, go in this order. Did I evaluate it completely in all aspects? Did I explain to the patient what is mine, according to my knowledge, what do I know, what is yet to be known, how is this journey going to be? The communication thing should be taken care. Then comes your management. You should have a proper treatment plan which is individualized for the patient. Then after you have prescribed morphine, you should continuously monitor morphine or fentanyl patch or buprenorphine or whichever opioid or whatever for that matter. We have to keep monitoring for the original symptoms, how it has come down. Are they developing side effects or any toxicity seen, or any complications are happening? Meanwhile, as a disease is progressing, some complications can happen. All these things will pick up only during monitoring. And then the last one is attention to detail. Not always a single mind can help. We should put collective knowledge so that we can do the best for the patient. So this is also a same thing. This slide tells 4A's approach. Same EMA mnemonic only, like analgesia. We have to optimize the pain relief, then look for activities. By I'm treating the pain, but is a patient having a quality of life, functionable quality of life? All such things also we should be asking. Am I looking for the adverse effects of the medicine what I have written? And is there any apparent drug taking behavior or addiction related behavior in my patient? This is very important nowadays. Though it is not happening in India, it's not very common in India. Already other countries like US and the global north has seen this, so we should be aware of these things. That should not happen in our country also. So we should be very much aware. I am sure you would have seen in your module the opioid use disorder questionnaires that can be used if you have a doubt, or you better refer to a psychiatrist, and they will also do this addiction screening for our patients. So multidisciplinary team comes in handy in such patients. And then the last but not the least is the fifth A, which was added later, is affect. So many times they say that in a chronic pain patient, the odds ratio of developing depression is 3.1. It is very high. When somebody is already in depression, those patients developing some chronic pain or new onset chronic pain is little less. It is also significant, but some chronic pain patients going into depression and anxiety is very high. So we should know to use, we should have a handy tool to look for those for that thing and treat that. Then only efficiently you can treat your pain. So this is I just directly, when my slides are not sorted very well, I'm sorry for that, but still this is one of the, when you come to the opioid rotation, you would have had a module on that opioid rotation. When should we do opioid rotation? Can any one of you volunteer and tell when should we really rotate opioid? In my early career, many times I used to tell morphine is not working, I should go to some other opioid. Then I'll call up my senior palliative doctors and ask, like I have asked Sunil sir many times. I used to call Dr. Sridevi many times, and should I really change this? What is happening or not? We will always have this doubt in mind. So, any of you have had such experience? Can any one of you share your experience? When should an opioid be rotated, changed? Indications of opioid rotation.
Anybody can unmute and speak. Please talk about your experience. If you have used opioids in your practice.
For example, I think even if you have not used morphine, many of you would have put buprenorphine patches and then felt, oh, this is not helping, I should change from buprenorphine to something else.
Ma'am, when the side effect is more as compared to the desired pain control, that's when we switch to other opioids or other drugs.
Yeah, that is one of the primary indications of opioid rotation. So, did you have any experience in?
Yes, ma'am, we did actually. The patient, we had put her on IV morphine because she was not able to tolerate it orally, and she started developing severe constipation.
Okay.
So after that, we switched it back to fentanyl, and then her pain was under control, ma'am.
Okay, the fentanyl, and how long fentanyl?
Fentanyl, ma'am, 50 mg patch for 72 hours, ma'am.
Okay, okay.
Sorry,
So
50 microgram patch.
50 mics patch for 72 hours. So, and
Yes.
the constipation was treated.
Yeah.
And then were you be able to go back to morphine, or?
No, ma'am. We with fentanyl only, the pain was moderately in control, and the patient was also very happy. She didn't wanted to take the 4-hourly medication. So with the patch, it was very comfortable for her, and she didn't wish to go back to morphine.
Okay, so it is interesting to know the story. Maybe we can come back to the story, how long it is sustainable to put fentanyl patch.
Sure, ma'am.
In your case, was it cancer pain?
Yes, ma'am, cancer pain. But the good part is that in my previous organization where we are practicing, fentanyl patch was available for free. So that's the reason, yes, that was the only reason we stick. to that.
Okay.
I was practicing in State Cancer Institute. So
Okay.
there we had fentanyl patches for free, and that's the reason we could give it to her. Otherwise, it's very expensive.
Okay. So you yourself have told the answer also. It's really not sustainable to continue
Yes,
fentanyl for a
ma'am.
long time. But fentanyl definitely has less of constipation. But generally, for constipation purpose, opioid rotation by textbook, it's not generally done because every opioid will have some constipation. Out of that, fentanyl has relatively less. So we should find out other ways of treating constipation. Than changing for this sake. Maybe for a short duration, you can definitely do whatever you have done for short duration until things are under control. Then you can again try back with morphine if required. We could have tried. So one of such indication is whenever the toxicity goes up. For example, in a renal failure patient, CKD patient, I cannot give morphine. Constipation was a different example. If you consider CKD patient, it is a classic example when you feel, okay, I cannot now give morphine, renal parameters are going down. Then what should I do? I have to change to some other thing like either buprenorphine or fentanyl or even methadone. But for everything, we have to know how to do the dose changing. So you all would have seen the opioid equianalgesic doses. It comes in a table. We do not have to memorize everything. Every time you should keep it handy and check, go back and check for 60 mg. Like always have some platform to start with. The platform to start with is you calculate what is the single day oral morphine equivalent for 1 day. 24 hours OME you calculate. If it comes to 60 mg, generally we start prescribing 10 mg morphine 6 times daily. So it is 60 mg. So this 60 mg only will be there in many calculations. So the equivalent of 60 mg will be there in many calculations. You can see when you want to transfer to change it to fentanyl or to for whatever drug you want to change in opioids, strong opioids, the equivalence will be calculated like that. So to explain that only I have put this slide. In fact, like methadone, they have calculated for opioid naive dosing or patient who is taking morphine less than 60, you can very well consider them like a opioid naive patient only. Who are opioid tolerant patients? When should we call them that they are opioid tolerant? Any idea? Whom should we call naive? Whom should we call tolerant? Whoever is taking at least for more than a week, they have taken morphine or any strong opioid, you should call them opioid tolerant. They are already on opioids. Opioid naive means the dosage should be less and the duration also should be less. We consider them as opioid naive. So such patients, we should start with low dose of methadone. And then we have to give time for methadone to act. In between, if we have SOS pain, we can go back to morphine. So this white paper is the one which is very simple. In fact, I used to read on morphine from Oxford textbook, which gives a complicated way of calculation. But this is the easiest way. That is why I have put this slide. Easiest way to convert from morphine to methadone. This is very important. We should all know this because methadone helps in neuropathic pain also. It has NMDA action also. And it is really helpful in case of renal failure patients. And it is a long acting twice a day dosing is enough. So this is about morphine to methadone. And other opioids for that matter, buprenorphine or not, in your modules, they would have given the what you call the tables where you can change from how much is 60 mg of morphine is equal to 25 microgram per hour patch of fentanyl. When it is only 30 mg of morphine patient is taking, then 12.5 patch is enough if you are changing to patch. But only thing we should remember with fentanyl patches, only for stable pain, we can use a patch. When the patient is having incidental pain or a breakthrough pain in between, it's not only just the background pain or a stable pain. We should always remember that on top of the patch also, you can give an SOS medication and you should choose it wisely. With more methadone also, SOS can be added especially during transition, we can give morphine as SOS. With fentanyl also, we can use. Very many combinations are tried. Many people, in fact, when I started practicing palliative care, I did not have access to morphine. I had only buprenorphine patch and the sublingual buprenorphine 0.2 mg. There was one company which was giving sublingual buprenorphine, so I had access. I'll put a buprenorphine patch, and whenever the sudden pain comes, I'll ask them to put 1.2 mg sublingual buprenorphine. Once I got access to morphine, I felt morphine is the most comfortable thing to change doses, to give SOS, and to treat stable pain. I'll give you some example cases also for that. Before I go for the example cases and case discussions, I would like to give you some basic references where I do from this is a go-to website. Whenever you go to just type ESMO guidelines, the first link which will come in Google will be this only. For all your cancer pain related doubts, you can go through this. Already you have gone through in your LMS portal, enough information has been given to you. But in case you are not able to access those details, this is one of the very useful resources for all your opioid related conversion tables are there in this, and reassessment things. So it is a 25-page document. It will be really helpful for you for practicing and prescribing strong opioids. The other important guideline, resource which I would like to suggest, which I personally use, is NICE guidelines for chronic pain management. This is a very quick read. This also is a 25-page document, but you just type NICE guidelines for chronic pain. This will be the first link which comes in your Google. So it gives you step-by-step for evaluation, evidence-based, everything is there. It is a go-to resource for planning your treatment and management. So then we will go for some case discussions. So far I have told you how important is evaluation again and again to plan our prescriptions. So I will discuss some few interesting cases, how I prescribe morphine, how I started prescribing morphine. So this was an interesting case. She is a very thin-built lady, 63-year-old lady. She presented to our hospital with right-sided limb weakness. So she was thought that this is CVA case, and then they started working up in that background. And she also had incidentally right-sided chest pains. I'm very sorry for those spelling mistakes there. I was in a hurry to make these slides. So this lady, she had chest pain. She was a single mother. She is from a remote village, at least from Coimbatore. It is some 70 kilometers from Coimbatore. So she traveled all the way to the second daughter's house here. The husband is not there. The elder daughter is also a single mom, managing with very minimal financial supports. Not a very affordable patient, not even lower middle class. They are below poverty line kind of patients only. So what happened was she was started on antiplatelets, given that loading dose and all, and sent to our hospital. Coming to our hospital, when basic chest X-ray was taken, it showed pleural effusion, and then her weakness kept increasing. A CT brain was done. It showed a space-occupying lesion. So it was not CVA, it was a brain mets. And this patient was having both headache, vomiting, and then right anterior chest pain. The chest wall, right side, she had severe chest pain, and whenever she takes a deep breath, she'll have a catchy pain and she'll stop breathing. Because of pain, she will hypoventilate. So that was a situation when she got admitted, and the pulmonology department started working up, and the biopsy, they found a solid mass in her right lung, and they did a biopsy, and it showed a poorly differentiated carcinoma. So I have divided this case scenario into part 1, 2, and 3. So what can we do for this kind of severity pain? Her pain, if I draw a body map for this patient, her main concern was the anterior chest wall pain, not even that breathlessness. The anterior chest wall pain was a main concern. As I am treating and evaluating pain, the treatment from the pulmonology side is also going on. They are planning for a ICD insertion after the biopsy. So she was telling the biopsy site is paining and my whole anterior chest wall is paining. So what was my plan to start was, let us see what I prescribed her. I told you she's a very thin built lady. So this is my hospital prescription. This is how we write a morphine prescription. I posted, I don't know how clear it is to you all, but I'll read it out. There is a small error in this prescription. I'll tell you what is the error. Morphine, I have written 5 mg. There is no morphine 5 mg tablet coming, but it is my copy where I have written in a hurry. So it is generally written 10 mg and half. Because she was a very thin built lady, I didn't want to start with 10 mg 4th hourly. What I have done, you can see here, I have written 6 a.m., 10 a.m., 2 p.m., 6 p.m. and 10 p.m. At 10 p.m., I put a double the dose. So 5 mg every 4 hourly by the clock, by the mouth, like WHO pain ladder we have properly followed. Because the pain is severe, step 3 opioid we have gone directly. All of you agree with that? So finally for the night, she should not wake up in the middle of the night with pain. So double dose I've given. Okay, then always we have to add prophylactically treat vomiting. So for 3 days only, I have given Perinorm TID. This is the dose we do. And then bisacodyl is a stimulant laxative. I have put 2 in the night. That is 10 mg in the night. This is the same patient who came back and told, don't write 2 tablets for me. I'm getting loose stools because of all these 2 tablets. Reduce it. And later on, I reduce this. And then the last thing you can see is amitriptyline, because she was having some kind of radiating pain from her low back also. I'll tell the story of that later, but she was having I have given half a tablet of amitriptyline 25 mg. It was a neuropathic pain. She told shock like, so I have added this. This is a co-analgesic, or you can call it as an adjuvant. So this is a very typical prescription which you do in palliative care, especially in cancer pain. You see an opioid, a strong opioid, a drug to handle the side effects of the opioid, and an co-analgesic or an adjuvant analgesic to treat the other type of pain also. So any of you have any doubts in this prescription, or do you want to ask me any questions why I started with this?
You have mentioned about 3 parts. On the cancer-directed treatment, and then the pulmonary medicine-based treatment, and then the pain management. So,
Yeah.
What was the pain management assessment? What is the type of pain, and can you elaborate on that?
Yes. That is very interesting. So when I saw her, the most of the pain was with deep breathing and all over the anterior chest wall. So I consider it as nociceptive and visceral type of pain, because the lung mass is seen, and there was pleural effusion which was causing her difficulty in breathing. Basically, it is nociceptive. But the same patient was always also telling she had a brain mets, right? So she was having some kind of neuropathic shock-like pain, or she used to tell some kind of numbness also. So for that purpose, I had added this amitriptyline. No other place she had much of pain. These were the 2 places she told pain. That happened in the first visit.
Can I ask you, in this situation, the pleural effusion may not cause significant pain. It is actually breathing difficulty that is, and the inconvenience to lie down. Those are the common symptoms associated with the pleural effusion. So
Yes,
have you evaluated the patient for any related lesions,
Yes.
especially directly involving the lesions directly involving the pleura? And second, have you evaluated the patient for bone metastasis?
Yes. That was done, and she was found to have both bone and brain metastasis. That's what I was like about to tell you. She had one mets in the vertebra also, and one on the rib also.
Maybe that is the cause for the pain rather than the pleural effusion related. So actually,
Yes.
if it's not a significant pleural effusion, we can even wait for the pleural effusion tapping and then probably go with the the
Yes.
primary modalities of cancer treatment, so that also, as you have mentioned earlier, can reduce the pain
Yes,
significantly,
absolutely.
because the volume of the
Yes.
disease can be reduced.
Yes, absolutely. You brought up a very important thing. This concept called correct the correctables is very important when we are doing any reversible cause should be treated uh, as we encounter. As you told, if it is only because of pleural effusion, if you treat pleural effusion, our dose of analgesic would come down. And in fact, as you told, it happened for that patient. So I will come to the next part of my story now. So this same patient, right? I started on this morphine, and 2-3 days she was very much okay, and she went for all this uh, biopsy report, everything waited. She arranged money. Then they had put a ICD for that pleural effusion, right? That time her pain exacerbated. So what I had to do was, for the same patient, I had to increase the as I made it like 10. From 5 mg, I had made it 10 for 3-4 days. After that, at least after 3 days, they called me from the ward telling patient is getting drowsy, she's not having any pain. So I saw her after making 10, 10, 10. I visited on the second day. She was very happy and pain free. The third day, second day I met her. Third day I couldn't meet her. Day after I'm going and seeing her, she was drowsy. So that is where our monitoring comes in. Then I again brought back to the same 5, half I made it. And then she was comfortable. When she was discharged to home, what is the total dose she is receiving as per this prescription? Can any of you tell? OME 24 hours ke liye, like what is the oral morphine for 24 hours she's taking? 5 plus 5 plus 5 plus 5, so 20 here, and then 10 here, so 30 mg, right? So what I did was, when I sent her home, discharged her home, I made like 10 mg morning and 10 mg in the night and 1 SOS. Then I told them to call me back if in the night the pain is going to be severe. We can even make it 10 mg in the morning and 20 mg in the night. So it totals to 30 mg total. And I told her, as SOS, you can have half a tablet of morphine in between. So when the pain gets stabilized only, we can change over to long-acting morphine. So until these kind of procedures like ICD is happening, patient is going to sit in the oncology for queue for a long time. They have n number of scans pending, all this workup pending, and all. Patient will not have stable pain for every biopsy and for every X-ray taken and for every procedure. The pain will keep varying. So we should have some leverage for changing like SOS doses in between. Once the pain is stable, we can change back to the sustained release dose and keep only bisacodyl, and perinom will be only for 3 days. After that, they won't have vomiting. So far, I have not seen a patient who required perinom for more than 3 days. Within my small experience, I have not seen anybody coming back with vomiting. And for this patient, amitriptyline was going on for quite some time. And at one point of time, morphine was stopped, only amitriptyline was going. And then I'll tell you her story, what happened after that. So as I told, she had that rib meds and all that. This ICD pain was handled with increase in morphine for a duration of only 3 days. And the third day itself, patient started becoming drowsy. So we had to again come back to the previous prescription and then change it to SR and then discharge her. After she came for the first refill after 15 days. We write refill for generally only for 15 days, only for exceptional patients who will tell that I'm coming from very much far away, madam, write for 1 month. Such patients, very reliable only, we write for 1 month, and it is very exceptional cases. Generally, I write for 15 days so that they come back to us. We know the status of the patient. If the patient is mobile and good, many times I'll ask the patient himself to come. Or if sometimes patient is kind of bedridden, patient can't come, I'll ask the attender to come, make a call and talk to the patient in front of the attender. ask the questions what I wanted to ask to the patient, and ask the questions what I wanted to ask to the attender, family person, then decide the dose, or if it's stable pain, I continue the same dose, or I increase it or decrease it accordingly. So this patient, after 2 months, she didn't come back for refill at all. Then 3 months later, then I am seeing that patient's daughter joining my hospital as an employee and telling Amma is all right now, madam. She's even walking now after physiotherapy. Physiotherapy we have already involved. So the patient who had that hemiparesis was able to walk. She went to the toilet on her own. She went back to that village with my elder sister. So everything is going on. I have joined for work here only. On and off, I'll come back like every 15 days. I'll come back to you for morphine. Or if you are insisting, I'll get my mother also, she told. Then after 2 months, there was no noise. For up to 2 months, there was regular follow-up, 15 days once she came, took morphine and all. Then lost to follow-up, I thought. Then 3 months later, she comes with a fracture femur. She already had a osteolytic lesion in the femur also. So what happened was the pain became severe. But that time, should I consider this patient as opioid naive or opioid tolerant? What should I consider her as? Any ideas?
Opioid tolerant.
Opioid tolerant. But to my surprise, this patient, I did not start back on morphine. I suddenly get to know that this patient is posted for surgery, and the orthopedician is calling and telling, madam, this one patient you have already seen in palliative. She has come for femur nailing now. She has got a femur fracture. We are nailing her now.
Ma'am, has she ever received any anti-cancer treatment? Just out of curiosity, I'm asking, because this presentation can be more like a small cell lung cancer. It's a poorly differentiated cancer. So I just wonder what was the cancer part of it.
The cancer part of it, I
To
do
add
not
also,
have
I would
the
like to ask if she got any radiation. Because a
this
lot
patient,
of these symptoms, they improve with radiation.
yeah, she was sent to oncology. I think she had radiation also. That's how I told you she had a brain mets, right?
Ma'am, this presentation is more likely a small cell lung cancer, which is showing pleural effusion, rib lesion, vertebral metastasis, and brain metastasis. This presentation is more like a small cell lung cancer, which can respond to both radiation as well as to chemotherapy.
Okay. So this patient did not undergo chemotherapy, to my knowledge, but she underwent radiotherapy. I told she had a brain mets, right? For that, she had undergone a radiotherapy, and for the mets in the spine, she had a radiotherapy. And then for the femur, there was no radiotherapy given, but this femur lesion was not there when they did not go for a PET scan. They did only HRCT, and CT brain was done. The femur lesion was not identified before, only the brain was radiated, and the spine, she got some radiotherapy for that. I might be wrong. She might be having the oncological part of it might be, there might be a gap there, but her, I think I should go back to my case files. In a hurry, I would not have put the right pathological diagnosis there, but the pain part of it is very much there in my register because I would have followed up. So we can definitely come back to that. So 3 months later, when she came for fracture femur, definitely a fracture femur will pain, right? So how did the ortho people handle the fracture femur pain? They never called me. No palliative referral was given again. They had given Fenta patch for her, and then they have given her some paracetamol, ketorol. They have managed with that fentanyl patch. After surgery also, she was given a fentanyl patch. The only 2 fentanyl patches she received. Surgery was done. Surgery was done under spinal anesthesia for her. She did not even get an epidural. And post-op, I was expecting they will call me for pain or anything. Should I really restart morphine and all? But they never called. Only NSAIDs and opioids were, tramadol was given, SOS, paracetamol, and ketorol was the only drug which went. After that, the patient got discharged. She started walking back. She was mobilized, and 5th or 6th day she was mobilized, and she got discharged. But we told that you have already got a pathological fracture, so you have to be careful about this. And after that, she has not come back to me still with any other pains. But she definitely got RT, that I am very sure of. But this chemotherapy, to my knowledge, she has not got any chemotherapy. There might have been any affordability issues also for why they would have refused. But I do not remember that part of what chemo was suggested, was whether chemo was suggested and the patient refused. I am not very sure of it. But the pain part of it, this was how it was managed. So we considered this patient as opioid naive because for almost 1 to 1.5 months, she was not on morphine. She was doing her daily activities. Her ADLs were good. She was going to the toilet on her own. She would hold the wall. She'll walk to the toilet. She'll be in the room. She'll be sitting and helping her daughter to cut some vegetables, and then she'll be on the bed again. Then she will not walk outside the house, but she was inside the house. Her ADLs were okay. So, any other thoughts or any questions regarding this case?
Ma'am, this case really reiterates your important statement of a multidisciplinary involvement in planning the management from the very beginning. The pulmonologist, the oncologist, and the palliative physician and the caregivers together, if they can take a decision and a call, including the pathologist and the radiologist, probably that's a wonderful thing that would have happened to this lady. That is my comment number one. And second thing, we have to do a immunohistochemistry for this poorly differentiated carcinoma to rule out small cell lung cancer, because that will change our management plans altogether. That will improve the kind of the quality of life of the patient with the systemic treatment, which is very cheap. Cisplatin and etoposide is very, very cheap. It's less than 600 rupees. So that is again an important aspect to be considered. Third, compartment-based treatments are happening. That is, as you have mentioned, in all events, including a fracture. Again, a collaborative discussion, multidisciplinary discussion is not happening. That is the unfortunate part I feel, because as you have mentioned, you have been not consulted, not reviewed. So that is always causing a significant financial as well as other concern for the patient, not in the right direction. That is my take on this.
Yeah, that's true. That's right. Because the third 3 months later, what happened was patient directly got admitted to the ortho department with fracture. That time, the primary consultant was not the oncologist or not the pulmo. Pulmo was the parent department. In fact, most of my practice, 70% of my cases are lung cancer patients only. So it didn't happen. Next time, in fact, she walked back. Again, the physio was involved. Even for the first time when she came with features like CVA also, the physiotherapist have helped to make her walk again and all. Second time also, physiotherapist was involved, but the palliative consultation did not happen. And it was not a very good multidisciplinary that the second time. So, okay, then we'll move on to the next case. This is also
is that this pathological fracture might have been exacerbated by physiotherapy if they were being a little aggressive about it.
I'm not getting you.
The pathological fracture, it may be due to excessive physiotherapy also. If they were not doing it properly, or they were being very aggressive with the physiotherapy and mobilization. That could
No,
be one.
No. That was a clear history of fall.
Because I've had a patient who had come following a back massage, they developed a fracture.
Oh, okay. Okay. They had an osteolytic lesion and it fractured because of the massage, or a normal bone?
In this case, it turned out to be a normal bone.
Oh, okay.
The prostate cancer patient, we had initially suspected it was metastatic, but the work had come out as negative. But initially, we were thinking in terms of an excessively enthusiastic massage.
Okay. Okay. So, but physiotherapists or definitely professional people, once they are acquainted to the onco patients, they will take care. Or sometimes if we are in a hospital which is not exposed to onco patients, no, we should write some extra notes to them that this is a patient, she has a scapula med, she has a rib med, all such things we should actually write and send to them, as you told. That's a very significant point, that we have to coordinate with the other team members also. Just by writing in the reference doesn't stop. Sometimes we should not hesitate to take the phone, call them and speak, or we should ask them what time you're going for rounds. I'll also come and see the patient that time. And then you discuss things bedside. Many solutions will be got when you discuss things bedside.
Ma'am, I feel that there are two things which are taking away our multidisciplinary discussions. One, our busy OPDs. So especially in government-based centers, it is very difficult to hold multidisciplinary tumor boards because you are seeing a lot of patients, more than 60, 70 cancer patients, means it is very difficult to hold multidisciplinary tumor board. Second thing, I have seen that in a lesser number of patients hospital, I mean the private setting, the consultant may feel that you may lose the importance, or the multidisciplinary team will decide another management, so that I will lose my control over doing surgery or things like that. So that also has been taken a toll on this MDTB. So I think we have to this is an important step that we have to take forward, because multidisciplinary tumor boards will legally protect us, will give benefit to the patients, and will give us to select appropriate treatment and more optimum treatment, I would say.
Yeah, that's right, sir. That's absolutely right. Forming a multidisciplinary team is really difficult, as you told. We may not get like-minded physicians to work with us, and it once you form it, it will be very nice to practice. And tumor boards, as you told, not every time one person will, everyone will treat others in an equally significant manner. It happens everywhere. So these are the things which we have to cross. Okay, coming back to our pain prescribing, next case is also an interesting case. We'll go for that. I have not got the story, but I will narrate the story. I didn't have time to write the story. This is one of my very early time patient. This patient is there with me for 1 year now, still on morphine. Almost 1 year. I saw her in first time when I saw, she did not use. I stopped morphine for her. Like the same story, same thing. Biopsy was taken, ICD was put. Very similar scenario, but no brain mets. Okay, but no brain mets. She had one rib met or something. Not even rib met. She had thyroid gland. She had a metastasis in thyroid gland, and one small rib met or something was there, and she used to have a stable pain. In fact, after that ICD and all, ICD was removed and all, I literally stopped morphine. They never came back for morphine. After some time, when some 6 cycles of chemotherapy was over, they came back with the pain after some few months, 3-4 months later. They came back, and because I had given morphine in the first admission, they knew that this pain has relief. So that is one of the small success in our good communication training, that they know that where to go for. If I have pain, where should I go? So next time they came to, not even to the pulmonologist, directly they came to pain and palliative OPD and told, we have finished our chemotherapy, but again my chest is paining and that same rib is paining. And restarted on morphine. She is on stable morphine for quite some time. And this 9th month only, I had changed to 20 mg SR. It's a stable pain. You can see this is a typical prescription we write. This is almost for past 4 to 6 months. This patient was already on morphine only when I have written this prescription. And what happens is, this lady with this morphine, she used to go for, I don't know, government scheme is there for employment for villages. They call it in Tamil Nadu, they call it Nooru Naal Velai Vaippu Thittam, 100-day work opportunity for village people. They'll just, for road cleaning, for digging ponds, cleaning ponds and all, they will call the VAO, village officer will call the ladies or whoever is sitting at home. They'll give 100 rupees per day. 100 days you will be employed, 100 rupees will be the earning. So this patient with this morphine, she used to go for that job. She had 4 daughters. 3 daughters were married already. The 4th daughter is yet to be married. So every time she comes to meet me, she used to travel like more than 120 kilometers to take this come for prescription. So you can see this is one of such exceptional patients. I write for 1 month. Otherwise, generally, I do not write for 1 month. I write for 15 days only. But for this patient, I write because she has a stable pain and she is young. You can see her age, 45-year-old. So the husband or herself, they will call and tell that my pain is so and so, my symptom is so and so. I can predict that if she has vomiting in between during chemo, I had put for vomiting this patient, I had given her for some time lot of nausea drugs also during chemotherapy. But after that, all that settled and she is on stable pain for quite some time. And even now she is on the same dose only. And dose did not increase. She's continuing to take chemotherapy now also, but from general hospital, because she couldn't afford to continue with our hospital. She went to general hospital, but for pain relief medication, she comes here. Any thoughts on this? What else should we monitor when patients are on chronic opioids like this, chronic strong opioids like this? What all should we like, if you recount whatever I told in that EMA approach, what should we monitor? Any ideas?
Breakthrough pain.
Yeah. What?
Breakthrough pain. How much of the
yes, breakthrough pain. So reassessment of pain, it should happen and at every time. And then like 2 months once, I would ask her to do some renal function tests, or I'll send, generally patient will go for chemotherapy. That time they themselves will do all these things. So they'll come with reports most of the times. I'll ask those papers. Did you go for chemo? I'll ask, and then I'll see those papers and see what was given and all. And their LFT, RFT and all would have been done. That I'll ask. And then I'll ask, do you have any signs of like restlessness or bad dreams you're getting, or some kind of twitchings, which we check. If patient is there, we can check for clonus also. Toxicity symptoms we can check. Excessive drowsiness are you feeling? All that questions we should ask proactively. Patient may not tell, but we should ask proactively. So side effects also you should ask. Constipation is one of the commonest side effect which you should ask again and again. Are you passing stools every day? Is there any problem in passing stools? Are you comfortably passing stools? Sometimes they won't tell if it's hard stools also. So you should ask the questions in different forms again and again. And after 2-3 visits, they'll understand what we are trying to ask and they'll give proper history. But until they get trained, we have to be really digging and asking questions for side effects about nausea, vomiting. What other side effects we can ask for? Morphine side effects. What are the commonest side effects of morphine? So sometimes some people can have urinary retention also, especially in men with a prostatic problem and all. Some people can have urinary difficulty and all. So we can ask for, like, we should have a list of questions what we will be asking to find out the side effects of morphine, what we should be asking to find out toxicity of morphine. The commonest question is excessive drowsiness will lead you there. So ask for excessive drowsiness. Ask for some are you having some bad dreams and all. They will easily tell that this is happening in their own language. If you ask, most of the times they'll give you exact history. You can rule out both toxicity and side effects. So this is one classic example of long-term morphine. This is one other interesting patient. Anything to add?
I wanted to ask if the patient is having drowsiness, and how do you if the patient having severe drowsiness, they're not able to wake up the patient, will you immediately go for naloxone, or like how would you evaluate such a patient?
Okay, if patient is drowsy, then we have a drowsy patient in our hand who is on long-term morphine. For example, if you say the same patient, how much is she on? 20 in the morning and 20 in the night, 40 mg of morphine per day. So 40 mg of morphine and patient is drowsy. How will we evaluate now? We should see from vitals, how is the respiratory rate? What respiratory rate should be worried about? When you're in your modules, you would have read it, no? When do we call it respiratory depression? We should see whether patient is arousable or not. The next important thing we should check for is, we should see, is there respiratory depression? And in that case, if there is respiratory depression, we have to arrange for admission of the patient, stop the morphine, withhold. We cannot tell it as stop. We are going to withhold until we are going to find her right dose again. And we should search for the correctable causes, correct the correctables again. Is this nausea causing something? Is she emaciated? Is there any other complication of cancer causing this drowsiness? Is there any new brain met you have to think about? You have to think about, is she suddenly got diarrhea and dehydrated and became drowsy like this? Is her constipation for more than 3-4 days, or patients can even become drowsy by having prolonged constipation or sudden intestinal obstruction. And one more important thing is patient's renal functions deteriorating. That's why whatever morphine I am giving is becoming toxic for her. Is her liver functions deteriorating? Am I missing a liver met, which is or something? So we have to really dig in to the symptoms, and we have to evaluate properly again why this lady has become drowsy or like that. So if we are seeing a patient whose respiratory rate is more than 10 or 12, then we can be confident that she has not gone into respiratory depression. Less than 8 respiratory rate means definitely you stop morphine. Especially we have given a long-acting morphine. It should come out of its body on its own. I have really important, when we share success stories, we learn something, but I'll tell you some of my nightmare stories also. Once one patient was in severe pain for it was a peripheral vascular disease patient. Gangrene was there. He was already stented for his heart and for his peripheral, femoral artery stenting was also done. And then proximal tibial stenting was also done. Below that, there was occlusion, but they couldn't treat. So the interventional radiology people told no intervention can be done for this leg now. So it is going into gangrene and he is having severe pain. And this patient, I gave him, this was purely ischemic pain. And I am trying one after the other. Vascular people have put him on all this Clexane or whatever. Anticoagulant drugs are all going. Pentoxifylline is going. And I started him on amitriptyline. This patient, I had started him on amitriptyline because he'll always tell burning. Ischemic pain will also tell, they will tell burning only. And then he will take his limb up and keep. And I kept him on tramadol for 1 week. He was comfortable. So next time the same patient came and got admitted. And I gave him 5 mg. I wrote 5 mg morphine BD for this patient and came after seeing his things. This patient was going into CKD. As I told you, he's already a known CAD, chronic smoker, COPD, CAD, peripheral vascular disease, peripheral arterial occlusion disease. Now, no intervention from surgical side. So surgery people have given reference, and I wrote 5 mg morphine BD and came. It's a very low dose for a 60-70 kg man, right? But after that first 5 mg dose, he did not wake up for more than 24 hours. Patient was sleeping. His creat was 1.1, not more than 1.5, 1.1 something. And his urea was like around 50s. He never woke up. His after like the hospital dean is on the floor on next day rounds, like it was a Tuesday rounds. So dean is calling and asking, what is happening? Your patient has not woken up. Do you want us to shift him to ICU? What did you give? Then I've told, sir, morphine only. I'll just come and, but In fact, I was following up on phone. The nurse has already told me that patient is drowsy, madam. He is not waking up. First, initially, I was happy. After 5 mg morphine, he has slept nicely. But after 12 hours went over, then I got little worried. Then evening, I went, saw, then with nice shaking, he was waking up. Then I stood by the side. I saw the respiratory rate. I saw the vitals. Then the patient's wife was very happy, telling that after 1 week, now only he's sleeping, madam, let him sleep. Then I came home. The next day morning, I went to my theater first. I didn't see the patient, but I got handover from the nurse telling that patient is waking up only with if you shake him only he'll wake up. Otherwise he won't wake up. Vitals are stable. Saturation is fine. But then my seniors like Dean is asking what is happening with 5 mg morphine. 24 hours is over. Your patient is not woken up. This patient, no, next dose of morphine I never gave. He slept like that for 48 hours. He was drowsy. After 24 hours, he could sit up and all, but still he'll not ask for anything. He'll not complain of pain. It was in his system for quite some time. That was the bad lesson which I learned. And one more interesting scenario I will tell you with breathlessness. I had a really bad experience. When breathlessness comes, I'll tell you. So in this, after this experience, every time I'll see the past creatinine, past to past creatinine, what is a urea, what is a urine output, and then only I'll write morphine for these patients. Okay.
Did you attempt giving him naloxone, ma'am?
Huh?
Did you attempt giving him naloxone when you were suspecting that he might have maybe not tolerated the dose?
I gave him 5 because whenever I start with, because I
No,
saw
ma'am.
his creatinine
When he was
high.
drowsy and not waking up, did you give naloxone for reversal?
No naloxone for reversal. Why I did not give naloxone is I was very confident about his respiratory rate. If you, according to guidelines, based on respiratory rate only, we give naloxone. It is not, the endpoint is not wakefulness. If the vital signs are bad, then only when we are giving deep pain, this patient was waking up, right? And then the respiratory rate was very well above 12. And naloxone, one important thing is we should go through the this thing of it. Naloxone is very short acting. We should keep topping it up, like it comes in 400 mics or something, 0.4 mg or something, 1 ampule. We'll dilute it and we should dilute it into, we have a naloxone, but really I have not used naloxone anytime. I'll just every time take the ampule from the pharmacy and see, okay, how should I dilute it? I go through the books and see, but I have never used naloxone still. At least for palliative. In OT, I have definitely used, but in palliative settings, I have not used naloxone still. So we diluted, give 2 ml, wait for respiratory rate to come up, because we cannot reverse the analgesia. We should reverse only the side effect, the respiratory depression and excessive drowsiness. Once that is achieved, we should wait for the patient to recover on his own. And again, we should reassess every hourly. There is some protocol. Sunil sir might be knowing it better, but there is a protocol how often we should repeat naloxone, and every hour we should reassess the patient whether he is going back to respiratory depression. Then give 2 more ml of naloxone. Like 1 ampule will be diluted in 10 ml, and we give in 2 ml aliquots. So that's about naloxone. So, but for this patient, I did not use naloxone. Okay, coming to this one, this is the breathlessness case which I was talking about. This patient is 72-year-old. This couple, no, you can see them. They do not have children. This patient has got admitted more than 13 times in my hospital. Okay, the distress and suffering is like so much. They do not have children, so they don't have anybody to help him, to take him to the toilet and come back and all. What will happen is his primary diagnosis was COPD and breathlessness only. When he was getting recurrent exacerbations of COPD, HRCT lung was done, and a small I don't know what exactly the type of cancer is. Lung cancer was found. Radiotherapy was given for that lung cancer. Post which, it was a very small 1 centimeter lesion or something. He developed a pulmonary fibrosis and his breathlessness worsened. Already he was COPD, but not like on LTO, not on long-term oxygen therapy. But now After this radiotherapy and chemotherapy, what happened was, can you see a dermatomal distribution of skin lesions? What is this? Can anybody take a wild guess? Huh?
Herpes.
Yeah, exactly. This is herpes. So what happened after his radiotherapy, chemotherapy and all, he developed this lesion, herpes reactivation. It seems 6 years ago or some 10 years ago, he had one herpes. After the treatment, he had a reactivation and he had severe pain. He was on this carbamazepine for quite some time, and then we changed over to pregabalin later. For him to start with morphine, I was like little overcautious. I have written morphine 2.5 mg BD, that was the stable dose which now he is on currently. But before I started with 1 ml BD because I was so scared to start morphine for this patient. Because just 2 weeks or some few weeks ago, what happened was there was one patient with severe COPD, breathlessness. Every hour they will be giving nebulization. They'll put him on BiPAP. They'll give nebulization. IV bronchodilators are going on. IV steroids are going on. It is like refractory breathlessness. Then I wanted to give morphine for this patient. I wanted to give when I was around in the hospital. So this patient, I gave telephone orders to the pulmonologist, and pulmonologist wrote the morphine for me. So 1 mg stat was given IV, not this patient. I am telling the previous experience before this patient, why I was scared and I started with 1 mg morphine for this patient. For that particular patient, he was not a cancer patient. He was only COPD. So 1 mg morphine IV was given. The biggest mistake I did was I didn't give Perinom for that patient. This patient was on NIV. His all this pain and breathlessness all reduced. For after 3 hours, I went, saw the patient around lunchtime only. Morphine was indented, got. I wrote in the morning. Morphine came in the afternoon. Dilution was taught to the nurse by afternoon. Afternoon only dose was given. When I leave the hospital, I saw the patient. Patient was doing fine. He was comfortable. Now he accepted NIV also. Then again, they put the harness. After I came home in the night around 8 o'clock, they told patient vomited inside the NIV mask. He aspirated and he died. So this patient, why I started morphine was the pulmonologist was telling. I asked him that surprise question we asked. No, sir, what do you think his prognosis is? What if we don't give morphine also? You are telling this breathlessness is refractory. What if we don't treat it with morphine? Then also, madam, he is already super anxious and he's going on. He's not accepting NIV. He will go into respiratory failure and he might not sustain for a few days. That is what the pulmonologist was telling. So then I thought, why not we give morphine in such a scenario? But I gave morphine and the patient died on the same day. That was, I had not prescribed antiemetic for that patient. So I should have preemptively given antiemetic first, and I should have gone for a subcute morphine or for oral syrup instead of going for that, going for IV morphine that time. So for this patient came within a month or so. So I was super cautious. Though he told pain, he had this herpes pain also. I gave only 1 mg morphine to see how he's tolerating. Then what happened? This patient, he started walking to bathroom after taking that morphine. That breathlessness will be less, not because of the pain. Then he only, like I have told him, as 1 mg, you can take SOS also in between. Then he himself helped me to design the dose. Like after 4 hours to 5 hours, he'll take 1 more mg. Then after 4 or 5 hours, he'll take 1 more mg. Then I totaled it up and saw after 4 days how much morphine he was on. It was like totally something like 6 mg or something only came. So I made 2.5 BD and 1 mg SOS. I used to tell them, you can take at least 2 doses of SOS whenever you have pain or breathlessness, whenever to feel comfortable. So this patient was additionally on pregabalin also. And you can see the multidisciplinary approach again. We called the physiotherapist to teach him deep breathing, to teach other maneuvers of how to, like after eating, you can see nasal prongs on his nose, right? He was on long-term oxygen therapy. When to keep nebulizer, when to keep oxygen, like after coming back from the toilet, how to sit, how to sleep, how to breathe, that pursed breathing and all, how to stoop forward to feel better. All that was taught to this patient. A hand fan was given. So close monitoring and thinking with in the multidimensional aspect is very important in giving pain relief. So this syrup morphine, such a low dose, also helped this patient. This patient is still on the same dose of morphine. So this is one other patient whom I saw good extreme pain relief with syrup morphine. This was my this was also a long back case only. Pediatricians called me and told we have given this patient presented with severe headache. This was neuropathic type of pain, some central neuropathic pain. So he had acute demyelinating encephalomyelitis. He was evaluated with multiple tests. The tests are going on one side. The father will not be able to arrange money. He'll take some 3-4 days time to arrange for one test. Then again 3-4 days to arrange for the next test. So many things. He was on some IVIG and all. He was on some immune modulating drugs also. And everything will be costing like more than 20,000-30,000. And every time you write a new drug from the pediatrician side and the pediatric neurologist was taking care. So whenever they write the drug, they will go back, arrange money and come back. But until then, patient will be like in severe pain. He will never sleep also. And this kid, I had a video also. He used to nicely describe his pain. He will tell, it is like ant biting all over my head. From outside also it's paining. From inside also some pain is coming. Like this, the 6-year-old kid will nicely tell us. So what lesson what is a take home from this is, first believe the patient. Just don't assume that the kid cannot tell me what it is. So paracetamol was given, naproxen was tried, diclofenac was tried. Everything was on the top dose. For 7 days, pediatrician tried. He never slept single day. Then I started 1 mg morphine again for him. I used to like call back Dr. Sangeeta from Pallium India for assisting the doses and all. I used to bother the faculty from Pallium. Then I was not confident to start for a kid. Then slowly I understood this kid also required 2.5 mg as a stable dose. Initially for titrating, I used 1 mg. Usually in all other hospitals, morphine syrup will be made 5 mg per ml. But in our pharmacy, I can request the concentration. So for that small kids and all, since I was little scared to give a high concentration syrup, I asked him to make 1 mg per ml. So 1 ml will be given 4th hourly to see how it is there. Then I'll keep SOS dose also. Finally, I came to a stable dose of 2.5 mg. And this kid required morphine for 2 weeks only. By that time, his disease-specific management took over, his symptoms regressed, and he went home without pain. Morphine was also tapered and stopped. Like whatever 2.5 I had kept BD, this was made in the HS only. In the night only, I made 2.5 plus 1 mg SOS anytime. Then after some time, we realized that this 2.5 mg in the night was also not required. And he did not have much drowsiness and all. So 1 mg SOS I had kept for some time. The father understood very well. So sometimes he will himself give 2 mg SOS when patient is very much distressed and crying with banging his head and all. If he's doing, he will give 2 ml. So I have like told the patient like, if he's very much in severe pain, give 2 ml. Or if you see that it is a manageable pain, give only 1 ml. After a few days, they stopped the SOS also by themselves, nicely tapered and stopped, and the patient went symptom-free, got discharged. So this is about small dose morphines also making big changes. And titration is by close monitoring only. For this kid also, I had given Perinorm. I had taken a help of pediatrician to calculate the dose of Perinorm. First 3 days, I had given Perinorm. But I didn't give Bisacodyl for him. I gave, I think, Duflac, or I left it to the pediatrician to decide what kind of treatment to be given, prophylaxis to be given for constipation. I think we gave him on alternate days 5 mg Bisacodyl. The pediatrician decided to give 5 mg Bisacodyl on alternate days for this patient during that 15 days of therapy. Okay, any thoughts on this or any experiences, similar experiences where you have seen severe pain? No, WHO ladder, may like you crossed all that, third ladder you have come, you need a third ladder drug. And in this particular thing, I also wanted to insist in a pediatric, if you have finished the module, there is no step 2. Do you remember? From step 1, you can directly go to step 3. There is no use of tramadol in kids. Any thoughts on that? Okay, then we'll go to the next case. So this patient also, like I have, I put this as a generic case. Widespread, this is a lung malignancy only. X-rays like this very frequently will be coming. They will have all over the anterior wall chest pain. They will not point to any single place. They'll have breathlessness also. This patient also, you can see him with an oxygen mask. So for these patients, for titrating morphine, like you will have to follow the next dictum, like start low and go slow. For any CKD patient, for any liver disease patient, for any patient with respiratory compromise is there, breathlessness is there, anywhere, geriatric, everywhere you just start low and go slow. That is a dictum. Like how I told, always correct the correctables. This thing also you have to remember. So for him also, I started with 5 only. Then slowly I understood what is the stable dose. He was okay with SR morphine of 10 mg BD. Just 20 mg of morphine was enough for this patient. Paracetamol was going initially, but with paracetamol he did not have relief. With tramadol also he did not have relief. Tramadol we had given for this patient 50 mg PID was started. Actually, what will happen is only when palliative people go, we start oral medications. The primary physicians will generally start all IV medications. So for acute pain, okay, when they want to get symptoms under control, using IV route is not wrong, but we should always think about something sustainable. That's what I told about fentanyl patch also. So this IV tramadol, how long we can give? At some time we have to change over to oral tramadol. With oral tramadol, he was not very comfortable, so we changed over to morphine. With low dose morphine, he was okay. Breathlessness was also reduced, and his pain was also reduced. Such patients are like routine patients in this in our pulmo-onco ward. So this is one other patient's PET scan. Such PET scans we see regularly. Can you see where all the lesions are? What is this?
Liver mets, bone mets.
Yes. Yes.
Yes.
She had liver mets, and then you can see bone mets also.
Diffuse bone mets.
Yeah, diffuse bone mets are there. So for this patient,
And you shown the chest wall groups.
yeah. For what all can we do for this patient? How can you, like, if any of you can volunteer? Until now I have shown you examples of these many cases. What will you do for her? How will you approach? How will you evaluate for pain? I'm talking in perspective of pain, not oncologist will take care of the cancer part. For pain part, what can we do? What all should we keep in mind?
I think we have to have all 3 approaches. We have to have a multidisciplinary approach in this case also, because this is a high volume cancer patient. So we have to include the service of an oncologist, because the diffuse bone pain, there will be diffuse bone pain. So we have to involve an orthopedician to see whether there is any fracture, neuropathic pain we have to assess. And then also, this is a high volume disease, so he might have breathing difficulty as well. So we have to have a comprehensive approach on this. And about the pain, we have to assess whether it's a visceral pain plus a neuropathic pain component alone, or is there any exacerbation of any other. We have to we can manage him with probably morphine plus a neuropathic agent as well. To start with, because it's a large volume disease, so probably he can be directly go for step 3, and
Yes,
then
absolutely.
and then when if there is neuropathy component, we have to address that also. And along with that, my suggestion is if we can identify if it's as a treatable primary which may respond to say chemotherapy, probably the reduction in volume also might help in pain.
Yes.
Even though no, everybody knows that she's not a candidate for cure, but definitely reduction in volume will improve her pain.
Yes, absolutely. What you're told is directly step 3 opioids to be gone is right, because this patient actually had severe pain. She had, you see this chest wall, no? She had that chest wall side pain also. This a little bit of back pain, and then here it looks so much bad in this. When you have such liver mets or brain mets and all, what we should be thinking about is this rise in ICT. We have to use co-analgesics. We should use the right time steroids for when we have visceral pain. It might be bowel obstruction, or even what will happen when liver is enlarging with meds. What kind of pain will we get? What should we do for that? Will morphine alone suffice? Will morphine treat this this much?
That can stretch the capsule of the liver. That can produce again severe pain. So steroids should be added.
Yeah, steroids should be added. So we should be aware that when stable pain is there, we continue with morphine. When pain in the right hypochondrium is increasing, weight pain increasing severely, we should know when to add steroids. So we should be looking for that history. We should actively ask for where is your pain, how is that, is it worse than before and all. So we should wisely choose our co-analgesics also. We should not always be thinking only morphine is going to help me. As you told, neuropathic pain can come in any time at any point in a cancer patient. Okay.
One question: what other than morphine, which other analgesic you use for this visceral pain? Here, plus steroid, of course, morphine plus steroids. Do you use any antispasmodics? Is there any role?
Yes, yes. So when the pain is colicky, when the pain is like colicky, we can add buscopan. Hyoscine is in. If the pain is not colicky, it is dull aching. That is where the history comes in, the type of pain. The words they use to describe pain. When they tell it is spasmodic, it comes and goes. It suddenly comes and with a high intensity, then it goes away. Then such type of pain, we can add buscopan for such patients. Otherwise, for dull aching pain, buscopan will not help most of the times. Morphine only. And the steroid, adding the steroid will help.
And in your experience, how far you found that the cyclopam is useful? I found that cyclopam is a tough drug to give. Most of the patients says that it is intolerable. So what is your experience?
I have not used cyclopam in adults actually, but whenever I speak to like pediatricians for other causes, they write cyclopam regularly. And the gynecologists for this spasmodic pain, when gynec tumors come, I always discuss with the primary physician. If it's a gynec tumor and they tell this kind of catchy pain and all, after consulting with them, I add a drug. So I have heard many of the times gynecologists adding cyclopam, but I have personally never started cyclopam for any patient. Buscopan I have, because I'm used to buscopan. Maybe that's my training. I use buscopan more. Hyoscine butyl bromide comes, no, that means.
Buscopan is a better antispasmodic than the cyclopam.
Yes, agree.
Madam, if we give amitriptyline to elderly people, will it cause urinary retention?
At high doses, yes. No, it is not a common side effect like constipation. It rarely happens. One of my patient who had prostate megaly, he will, whenever the dose goes high, he will tell it is difficult to pass urine. Otherwise, it's not a routine side effect, but it can happen.
How often do you give amitriptyline to pediatric patients?
Amitriptyline. Amitriptyline can be given to pediatric patients, especially when neuropathic pain is said. But for this patient, I had not given amitriptyline. He was not. I have not given amitriptyline for pediatric patients per se, and I do not treat neuropathic pain in pediatric patients. So far, I have no experience of pediatric and amitriptyline. But I don't think there is a contraindication to my knowledge.
Punitha, can we wind up in another 5 minutes?
Yes, sir.
It's
Actually, this
already
is the last
7:40.
slide. This was the last slide, sir.
Okay, so if there are any burning questions, please ask it now.
About musculoskeletal pain, how will we combine muscle relaxants along with the pain management?
For musculoskeletal pain, are you asking about like something like chronic backache, neck ache, sir?
Yes, ma'am. Yes.
So these things have a proper way of evaluation, sir. Like chronic MSK pain is an entity by itself. I gave you one reference, like NICE guidelines. No, you remember that? I'll go to that slide. This guidelines.
Yes.
This will take you to a page. This PDF, they will give you in a PDF format, all my PPTs.
Okay.
So what will, if you go to this, that website will take you to all the chronic musculoskeletal pain also. How to evaluate and treat. That will be a good, useful resource. But generally, muscle relaxants are not immediately given. Like in an orthopedic pain and all, they combine a muscle relaxant and rate, like MR, like aceclofenac MR will be written for short duration. But for long duration, we do not tend to use muscle relaxants. If it fits in the chronic pain category, we should treat like a chronic pain only. For acute pain, like how you treat acute inflammation, no, like give rest to that part. Like if it is a joint pain, you give rest, ice, compression, elevation, and all we do. No, for any musculoskeletal or inflammatory pain, sports injury, what do? We do treat acute pain like that. We immobilize a joint, we immobilize a bone, keep it in rest, or keep it elevated to avoid edema. All those things we do in acute, but in chronic, the thing is different. So not always we will write a muscle relaxant.
Okay.
I
So
have few backup slides also, which you can use it when it comes in as PDF. You can use this stuff. It will be handy to assess psychological pain, assess physical pain, assess social and spiritual pain. These slides will be given to you.
okay, thank you, Punitha, for taking this much time, even after your whole day of working. So that was very interactive and enlightening session. So thank you for your time, and thank you everybody for joining us today. But it's all.
Yeah. Thank you, Sunil sir, for the presentation, but thank you, Punitha madam, for the wonderful session. And thank you all. We'll meet the next session. Have a nice day.
Thank you. Thank you for the interactive session. Thank you all.